over them, learn about the disparities that exist for Native American populations around heart disease. We're going to talk about 3 specific pathways that put Native people at an increased risk for heart disease. And we're going to learn about some evidence-based practices and culturally relevant interventions to prevent and treat heart disease. So to start out, I have to tell you a little bit about myself and sort of how I came to be interested in this topic. That's me and one of my sisters and my dad in the middle. The last time we went to visit a doctor with my dad, there was, I think, 5 or 6 of us there. Together, we like to go as a family. My dad, like many other Native people, especially Native men, suffers from heart disease. And again, like many other Native men, he was diagnosed significantly earlier than non-Native people are. So in thinking about my experience, sort of watching him kind of go through life and some of the stresses he's had to experience, some of the amazing accomplishments that he's had, it's kind of got me thinking about this topic area. And I was actually thinking this morning about when I was in graduate school, I actually went to, you'll see this person's name a lot in this slideshow, Ann Bullock, because I wanted to do research with my own community. But all of my training up to that point told me I wasn't going to be objective if I did something that affected me personally. So I went to Dr. Ann Bullock and I called her. She's now the director of the Division of Diabetes Translational Research at the Indian Health Service, and said, well, I want to research this. This is important to me, but I've been told I shouldn't because I won't be objective. And she kind of laughed and she said, no, this is what you need to be doing. This is the topic for you. And so you'll hear a little bit about statistics, and you'll also hear my personal and emotional, how I relate to this topic as we go through. Brief agenda. There's quite a bit of information here. It's kind of an information-packed presentation. The disparities, the role of stress in heart disease, what we know, specific health risks for Native people, and those recommendations again. So many of you might know, but when I say the word heart disease or cardiovascular disease, it's really a group of conditions. Could be congestive heart failure, stroke, coronary heart disease. It is the most common cause of death in the United States. It's also the most common cause of death for Native people. However, the rate of diagnosis and the rate of death is significantly higher, twice as high in the Native population versus the general population. Native folks have a higher prevalence of heart disease and stroke, and it also continues to rise as it's declining for the general population. So there's also a few, I guess, comorbidities or diseases that relate to heart disease in the metabolic family, including high cholesterol, high blood pressure, and type 2 diabetes. And we're even seeing in Native children that there's a significantly different rate of hypertension for Native children under the age of 18 compared to non-Native children. Then there's quite a lot of risk factors for heart disease. You can look at the Framingham risk factors. And for all of those things like high blood pressure, high cholesterol, physical inactivity, smoking, Native people are at increased risk. 28% of Native people in a study over 7 tribes were at risk, had one of these risk factors. So that would be high blood pressure, high cholesterol. 74% of Native people were overweight or obese. 41% smoked, and 52% lacked appropriate physical activity. And what is sort of most interesting and shocking about this is that, again, this trend continues to occur where cigarette smoking, for example, continues to rise in Native populations or stay the same as it declines for the general population. You can see this particular study shows that Native people smoke 41% versus 24% of the general population. These risk factors certainly aren't under control. Thinking about the effects that heart disease has on Native communities, I think is really important. So when calculating the premature death rate for Native people, it's 36% versus 17% for non-Native population. And there is a study that my tribe back in Tahlequah, Oklahoma, the Cherokee Nation Public Health Department did, and they found that you know, they were very concerned about heart disease in our tribe, and they calculated the numbers, and just in a 2-year period, they did 2012 to 2014, that there was 7,500 years of potential life lost. So that's a statistic that I think about and resonates a lot with me, because we're in a place, like many tribes are, that the knowledge and the relationships we have with elders are very important. We have folks every day. The number of people who speak our language decreases every day. And these are our culture keepers. These are information keepers and transmitters. And if these are, you know, if we have 7,500 years of this experience with our children and grandchildren gone, when I hear the words health disparities and health equity, it doesn't really get to how critical this is to me. This is more correctly summed up as being a cultural genocide. So that's just a powerful component of the importance of this research to me. Also, in subclinical research, that's that data that tells us what's going to happen before it happens, being able to predict heart disease. So Native people have 15 to 20% more plaque measured through carotid ultrasound, which is a significant CVD risk factor. So even being able to predict heart disease in Native people, it's so this is a bit of a dated map. This is the newest map that we have available, to my knowledge, and this has the heart disease death rates in the country for Native people. And I just wanted to give you a little bit of an image. Obviously, the darkest red has the highest annual deaths per 100,000. Can you all see that screen okay, or is it?
We can.
Okay, good. So you can see that many of the places that have a high Native American population, such as Oklahoma or the Dakotas, have higher rates. So I wanted to introduce this topic of the relationship between stress and heart disease. So stress is related to heart disease through a number of paths, and if you want to sort of do a literature review or learn a little bit about this, you would look at these stress biomarkers, measures of inflammation, heart rate variability, stress hormones, adrenal function. And stress has been linked to heart disease through a variety of different pathways. Like I just mentioned, some stress hormones, atrial fibrillation, vasoconstriction, additional fat deposits, and congestive heart failure. It's one of those independent risk factors. So you probably see this a lot. You know, here are all the risk factors for chronic disease, A, B, C, and also stress. And stress is kind of the last one, because I think it's a little bit, it's less understood. So for the relationship that stress has with heart disease, it is one of the Framingham CVD risk factors, but it is also an independent risk factor itself. So it is, to me, an even more powerful contributor to heart disease. It relates to both, increased stress relates to both pathology and also some of those psychosocial components of healthcare, like adhering to treatment plans. When you look at the literature, you'll see quite a bit around work stress and marital stress and how they contribute to heart disease risk. But what's interesting in the literature is that when people have stressful life events, there is a pathway to heart disease, but many of the times it's partially explained by mental health, depression in particular, and we'll talk about that a little bit more later. And we look at the trajectory of the lifespan. Early life and current stress is linked to mental health symptoms, and the stress that's coupled with that mental health status, depressed, have clinical anxiety, may lead to the risk of heart disease. So here's just one example. So over there on your right-hand side is the Beck Depression Inventory. And then we have the days after myocardial infarction discharge. And so you can see, even with a pretty low, a non-clinical amount of depression up top, there is a linear relationship between post-myocardial infarction and frequency of cardiovascular death. So that's important to note. And some of those risk factors that we've talked about that increase on the right-hand side, it has the relative risk of developing heart disease. And you can see that clinical depression is significantly higher than any of the others.
Would you rather we wait till the end for questions?
Go ahead.
Okay. So in working with Framingham data, it seems like different populations need to have the model refit. I'm wondering if any effort has been made to refit the model using longitudinal data in American Indian populations.
Well, I know there's been some problems with the Framingham risk factors. In the research that I do, I've moved to Simple 7. And I've noticed other researchers who work with this population have done the same. So I'm not sure if there's been an effort to refit. I'd have to double check. I kind of gave up on it.
There are many new framing scales now developed with apps and things like that by Harvard, by Yale, you know, but they all have used some refitted data.
So when you have to move it to like the Japanese population, all the coefficients change because
they have to change.
So it's probably why it's not worked very well for you. I'm thinking.
So this particular slide that I'm demonstrating or up here is not in a Native American population. This is general population. So again, kind of getting back to the relationship in stress and trauma and heart disease, a meta-analysis of stress in the workplace, again, this is non-Native population, found that heart disease was 50% more likely for those who reported work-related stress. It's also more predictive of heart disease than cholesterol. So some folks, in seeing this data, have thought about how they can intervene, and a couple of those, one in particular, cardiac patients that practice meditation and relaxation has significant reduction in heart rate, blood pressure, and depression. So that was a little bit of a primer on stress and heart disease in the general population. So what do we know in the Native American population? So one of those processes that we talked about was that process of inflammation that relates to heart disease. And there has been studies that have demonstrated that inflammation in Native population is also related to cardiovascular disease. So I'll talk about a few different specific stressors, but for those of you who might not know, Native folks have had a unique experience of trauma in the United States and around the world due to a prolonged history of stressors such as forced relocation, social and economic oppression, and genocide. So many Indigenous people today experience stress disproportionately through unemployment, discrimination, incarceration, violence, and injury. And Native people are not represented in most research on the association between stress and these heart disease risk factors. So what do we know? I'll just review kind of a few studies. So Native folks who have larger stress burdens are more likely to have type 2 diabetes, found in one study. In another one, those that reported being marginalized They define that as being discriminated against or even bullied due to their race were twice as likely to report a CVD diagnosis. And in another study, participants who had PTSD had higher BMI, triglycerides, and C-reactive protein measures than their native counterpart, their Native American peers who did not have post-traumatic stress disorder. And again, this is another example that the participants that did have PTSD reported more depression. So there is this mental health component of stress that is sort of appearing. So this is a model of the relationship between stress, the stress physiology, and metabolic disease. And one of the trends in the literature is that the mental health explains part of that relationship. And that sort of makes sense when we think about resilience theories. And, you know, if you take 100 people and you expose them to something traumatic, you know, a natural disaster occurs, not every one of them is going to have clinical depression. And there's many factors that would predict maybe who would have clinical depression, but we'll get to that. But I just wanted to kind of point out that mental health does play an important role in this relationship. So the three stressors that I'm going to talk about in particular are historical trauma, early childhood stress, and current and ecological stressors. So really quickly in the room, who's heard of the term historical trauma? Has anyone heard of that before? Okay, so in the room, most people have heard about it. I'm not going to go into it too much here then. And who in the room has heard of ACEs, adverse childhood experiences? A few. Okay, so we'll define that in a moment. And then we'll also briefly talk about some of those current stressors. So for historical trauma, when we're looking again at the literature, Dr. Whitbeck and colleagues created a measure called historical loss. And I just wanted you to get an idea of what some of those items would be. So when someone completes this measure, they're asked, how often do you think about the loss of your land, your language, your spiritual ways, loss of your family ties to boarding school, loss of trusted whites from broken treaties? And all of these components were created through a community-based project. So tribal members in the upper Midwest worked to create this measure. And then the second part of this scale is the associated scale. So how often do you think about the loss of your land? And is that related to, does that make you feel sad, angry? Does that affect your sleep, etc.? So what we know about historical loss is that over half of adolescents report having a daily thought, at least one daily thought about historical loss. We know that around almost a third of adults report multiple daily thoughts about historical loss, one of those items. And it is related in that associated symptom scale. We found that it is related to increased anger, depression, anxiety, suicidal ideation, interpartner violence, substance use, and negative image of yourself. And so all of these reactions, Maria Yellowhorse Braveheart has sort of said is called historical trauma response. It's unresolved grief associated with trauma from the boarding school era, prohibition of religious and cultural activities, and events that occurred during the removal and termination eras, for example. And this notion of historical loss is systemic in nature. It's a family event and it's a community event. So in one study, a mentor of mine, Dr. Walls, looked at 3 generations, grandparent, parent, and children, and measured historical loss. And what Dr. Walls and her team found was that historical loss was related to in all 3 of those generations, parenting style, likelihood of substance use, depression. Another colleague of mine, Dr. Myra, looked at 2 generations, found a similar pattern of substance abuse related to historical loss. And this last one, I think, is one of the most important because I think as Native people and minorities in this country, you hear a lot. That happened a long time ago. You know, just get over it. It happened. Well, boarding school wasn't that long ago. Many of our grandparent generations went to boarding school, but you do hear this. What's the big deal? It happened 50, 100, 200, 500 years ago. But what Dr. Whitbeck found, the originator of this scale with his team, was that looking over generations, the historical trauma for adolescents was actually higher. They had more thoughts than even their parents did. So even though events have happened historically, there is something important about going forward and how it affects our future generations. So the next kind of Indigenous specific stressor I wanted to share with you all is early childhood stress. And I'd like to share this quote as well. Many adult diseases should be viewed as a developmental disorder that begins early in life, and that persistent health disparities associated with poverty, discrimination, and maltreatment could be reduced by the alleviation of this toxic stress in childhood. That pretty much sums it up, but I'll give you a few more slides. Just some examples of how stress in our families and our environments affects our physical health. So toddlers who had an insecure attachment, if you go back to your Psych 101 classes, to their mothers at age 2 had a 30% increase risk of obesity at age 4.5. Another study found that young children who their maternal-child relationship that was kind of objectively measured by scientists had about 2.5 times higher risk of adolescent obesity than those who did not have a poor quality maternal-child relationship. And we know that for a child who has chronic exposure to parent and or partner violence, it almost doubles their risk of obesity by age 5. So going into those adverse childhood experiences, if you are not familiar, this is be a good Google search to do. There's a few different measures that people use for these ACEs, but many of them have at least, have about 5 to 7 of these components. So abuse in childhood before the age of 18, physical, sexual, emotional, viewing a mother treated violently in the home, substance abuse in the home, mental illness in the home, an incarcerated family member in the home, or parental divorce or separation. There's a lot of interesting data about ACEs. It is all correlational, just as a side note, but when you look at how many ACEs that there are, and you can kind of see this image as they go up from 0 to about 2, your risk is not too much higher, but about 3 and up, and obviously at 7, 8, there is a strong linear relationship between the number of experiences, negative experiences a child's had, and their likelihood of heart disease as an adult. An important risk factor for heart disease is smoking. It's kind of a similar linear relationship you can see there. And so this association between these childhood adversities and these adverse chronic conditions, and you can kind of go through the gamut of chronic health conditions and social conditions, and you'll see a similar linear relationship. But for our purposes, for metabolic disease, diabetes and obesity in particular, if you have 3 or more, you're 1.5 times more likely to have heart disease. You're 1.5 times more likely if you have 3 or more childhood adversities to have diabetes or severe obesity, part of that metabolic disease. And then over 2 times more likely to have heart disease if you've had 3 or more. You can check 3 or more on that list. And again, because we're kind of keeping tabs on mental health in this relationship, similar relationship with chronic depression. So just to highlight again, 0 ACEs is not really related to an increase in heart disease, but 3 or more kind of gives adults of this multiple risk factor for metabolic disease. And if you kind of are a betting person, or if you had to put money on, if you had to have one predictor for chronic health diseases in the United States, ACEs are the leading determinant of health and social well-being in our nation. So what does this look like for Native people? It's significantly different. So in a study that looked at 7 different tribes and looked at the rate of adverse childhood experiences for Native versus non-Native communities, you can see that Native communities experience significantly more adverse childhood experiences. And when you look at the very bottom, you can see that Native folks experience 5 times more adverse childhood experiences when we're looking at a threshold of 4 or more. Okay, and this is sort of the last part of those childhood disorders and stress. So I was trained in social sciences, so this is an area that is a bit new to me, genetics and epigenetics. And the woman that I mentioned at the very beginning, Dr. Ann Bullock, she let me use some of her slides for these presentations. So I just want to go over some of these things that I think are important, because in Native communities and research, sometimes the research that is done is based on medical beliefs and not Native beliefs so much. And so we've had a history of looking at kind of a medicalization of race with lots of communities, but for Native people, looking for the gene, the thrifty gene for alcoholism, looking for the gene for diabetes. And I think this will sort of demonstrate we might be looking in the wrong direction if we continue medicalizing race. So Dr. Ann Bullock taught me that it does matter what genes we inherit, but the proportion of the predisposition for type 2 diabetes, for example, it's very small, 5 to 10%. In addition to that, those genes that are associated with the risk are no different for different ethnic and racial minorities. And only 15% of these genes and these cells can be turned on at any one time, which does make us think about, kind of turn our attention to epigenetics. Again, so there's a lot of people here that have a lot more expertise in this area. So I'll leave the majority of that topic to them. But we know that epigenetics is kind of that on and off switch in relation to our genes and the environment. So what's interesting about some of these markers is that they're not necessarily reversible if they're turned on in specific, usually an early childhood stage of someone's life, and then they can be heritable. So then it kind of does turn into genetics. So if you are interested in learning a little bit more about genetics, you can look at articles about DNA methylation, histone acetylation, or microRNA.
Yeah, but it's pretty obvious for diabetes, which is a risk factor for heart disease, and it's in the genes of a lot of chronic disease in general, metabolic disease, that the genes accounting for diabetes is a very small component, like most diseases are. But also that gene, it's distributed equally for no minority. And we know that the Native Americans have a special case of diabetes. Best case scenario is being in Arizona, huge rate of obesity is both incidence and prevalence. So you start thinking 20 years ago, it's all genes. Now we know it's not genes. It is genes, but it's turned off by all those historical and stressors that we have in society that interact with the gene to actually make it become active and cause some of that. So when you see, a lot of race, sometimes not everything is even the gene. It's not the race, it's the environment. It's the context. So bottom line, social determinant is more important, in my opinion, everything I read in half your presentation, than anything else for many of the minority-related diseases we see here, including African American, including Hispanic, or any other minority. So I just wanted to make that comment.
Well, thank you. Much better said than I tried to do. These are all one. Sorry about that. So another important component to learn about is the relationship between low birth weight and preterm babies. They're both strongly associated with babies' later risk for chronic disease. And low birth weight is also related to the nephron number and the future risk of kidney disease, possibly diabetes. Excuse me for the misspelling there. So in this particular study, they found that one maternal stressful event during the first trimester increases the risk of preterm birth over 1.5 times. And then when we look at 2 or more stressful events, it increases to 2.5 times. And if we look at 2 or more stressful events in the second trimester, it's almost 3 times more likely to have preterm birth. So we know that it's very important for mothers and women to have kind of healthy lifestyles. And unfortunately, in Native populations, women have some of the worst statistics for safety. I wanted to share some of those with you today. I know there's a lot here, but I'll kind of quickly cover some of this information. So Native women that reside kind of within their jurisdictional boundaries suffer domestic violence, physical assault more than other women, and it's actually 50% higher than the next most victimized demographic in the United States. Physical assaults are higher. Native women are 2.5 times more likely to be raped or sexually assaulted than non-Native women, and that is about 34% of the population, or 1 in 3. 96% are victims of sexual assault, experience physical abuse as well, and at least 70% of the violent victimizations are experienced by non-Native people, which is a substantially higher rate than experienced by any other victims of violence. 39% of Native women are victims of interpartner violence, and that's again higher than any other race or ethnicity surveyed. So when we think about who are the most vulnerable people in the country to violence, it's women. And when we think about how important it is for women to have healthy pregnancies, this is a real risk. Yes, sir.
Are there studies that compare Indian population in and outside of the reservation to kind of see what is the importance of the reservation? Because you seem to imply here that the reservation
that was
a certain...
the first study found that, and I just wanted to make it clear. The rate stays the same as far as I know. Yeah, because there's the rate of Native people living on reservations. There's a lot of different numbers in the United States, but it usually ranges from 40 to 60%. So most people can say pretty safely that the majority of Native people do not live within their jurisdictional boundaries. Okay, so sort of to sum up about this, the fetal origins of health and fetal programming of type 2 diabetes, I'll just read a couple of quotes here. That this intrauterine environment may modify gene expression permanently and through generations. And the next one talks a little bit more about that it's important that the story that we focus on is not about the birth weight alone, which we know is important, but it's also about the fetal programming, that the intergenerational prevention of type 2 diabetes will need to target maternal health. And if we're really focusing on prevention of metabolic disease, we will need to concentrate on the health of young girls before they become pregnant. And that's sort of the key to prevention. Okay, the final stressor that I'd like to talk about is adult trauma. So compared to the US population, Native people experience more trauma to their loved ones. They witness more traumatic events. They're more likely to be victims of physical attacks. Native adults today experience disproportionate racism, discrimination, neighborhood disparities, financial disparities, and family strain. And this quote here kind of sums it up. American Indians live in adverse environments that place them at high risk of exposure to trauma and harmful health. And I just want to clarify that adverse environments doesn't necessarily mean poverty or lack of access to education and health, which are included. But what I really want to get at here, and there's some nice literature that looks at the experience of Native people and how it affects their health when you look at microaggressions in healthcare settings, for example. And a few of you I see here attended Dr. Anton Truyer's lecture a couple nights ago, and he explained it as it's hard for non-Native people to see the discrimination and microaggressions. And he said it's hard for them to connect the dots. And he said because there's an experience here that happens, and then one here that non-Native people see. But he said for Native people, these sort of unequal and discriminatory experiences happen so often, the dots are right in a row, that it's just a straight line. So I thought that was a nice metaphor that he used. So hopefully, Dr. Shuyer, if you're listening.
Can I have another naive question here? But I mean, I can understand how can you tell somebody is Native American? I mean, I think it's easier for the African American to tell them. How can you tell?
I might argue with you on that one too.
I mean,
So race, unfortunately, in the United States has been associated with skin color and a look. And so when I go to get health care, people say white because they expect a specific Hollywood look. So you can't tell by asking, you can't tell without asking if someone's Native or not, or if they're African American or not. This is a really complicated and a really good question.
it's
But so.
I mean, for me, they can tell that I'm not American because of my accent. That's easy. But in this case.
Well, and you're also talking about, in the United States alone, 567 federally recognized tribes, sovereign. They're their own country within this country. They have their own laws. They have their own police force, their own judges, their own beliefs about the world. So it is a disservice sometimes when we use this language, because it kind of prohibits us from seeing this, each individual culture. So I do have a paper that hopefully will be published soon that looks at the disparities that happen in healthcare for Native people. And I do have follow-up recommendations about that. And the healthcare systems that do really well, they ask those questions up front. How do you identify? I've written on a chart before how I identify, and it's never made it to my actual chart.
I think I have a possible answer for Dr. Popescu's question. Back in until the 60s, the American census used to have a very specific way to define race that has changed dramatically. How did they define race back then? As the observer, the surveyor made the decision about race. Mm-hmm. Over the past few years, the American census adopted what many Latin American countries have adopted for many, many years, which is you define your race because you know your history. And the person, may look one way, but feels the other way. And they also may know their history, may not know, mm-hmm. but they correlate. So bottom line is when people self-define, they're more precise. If you go to genes, for God's sake, almost a huge number of people here that they think they are white, they actually have American Indian gene as well as African American, because there's a lot of mixing of races all over the world ever. And if you go back to the mitochondria of your mother, everybody's being Africa. So genes, it's not a way to go. It has to be self-defined. It's a anthropological social construct. That's what race and identity is, and it has to be. So, and it's okay because it defines a group of people's specific experience. Likely the color of the skin is going to be more important for the reaction and for what you see today. But in the end, for science, it is not. It's how the person defines themselves.
Well, just my surprise that I see the same amount of discrimination like for African American, which is when it's surprising because I thought, that was basically the question.
Yeah. Well, I think what's interesting, and this is definitely a longer conversation, but depending on, it doesn't really matter how you look. For example, if you're a Native person and you're living in Columbia, Missouri, and you see a demonstration daily of Lakota coffee or a mascot Those are
I see.
microaggressions that occur. Doesn't matter what you look like. Now,
I see.
there are some studies that have actually looked at skin tone and demonstrate that those folks, that's kind of a quicker way for someone to associate with you with what they think you are. And that is certainly associated with more experiences of discrimination. But our society as a whole has rules about how things work, and it affects everyone. But that's a really good question. Okay, so now I've talked a little bit about some of these risk factors and how Native people might be more at risk for heart disease and some pathways that maybe we hadn't thought about before. And it really comes down to these two things. One, it's important to intervene at the right time. Two, population-specific interventions are very important. So the Center for Developing Child at Harvard University says, we know that sound maternal and fetal nutrition combined with positive social and emotional support for children through their family and community environments will reduce the likelihood of these negative epigenetic modifications. It increases the risk of later physical and mental health impairments. So the timing is important, prenatal. And so one intervention that has been able to show quite a bit of evidence in this area is, you'll hear the term prenatal or early life home visiting or nurse-family partnership. And so, so this improves the life trajectories of at-risk women and children, and positive effects longitudinally have been shown up to age 9. I like this quote from this article. They said, if home visiting were a medication, it would be malpractice not to provide it. It's been, I think this might be a little bit old, but as far as I know right now, 19 different tribes are using, have been funded to provide some sort of home visiting, and 9 of them have demonstrated an evidence of effectiveness.
Melissa, just a point I'd like to make about the home visiting program. It's a program, there's a specific way to do it. It's not just going to a home and visit. The federal government created this program about 10 years ago and fund every state, not specific for American Indians, but it's a statewide. We have one here in Missouri, and our department evaluated that program for 2 years into a $1 million grant from HRSA over the past 2 years, and it's pretty decent. It could be better, but the science of it is better than the practice, meaning the design studies done early on to prove that this is efficacious. It showed that it's efficacious, but as you implement with a lot of problems that we have, the effectiveness of this intervention, the real impact is being very small. That's what part of the indirect evaluation done here assess, because processes are complicated. But there's a federal program there, and it
I
should
did
be.
hear last time that there is a program here in Columbia too that I was interested
It's
in
called
learning about.
McVie. It's from the State Department.
What is it called?
McVie.
Okay.
MCVIEH. That's one of the programs, and then there's another one that Dr. Kemba was involved for 10 years.
Tips for kids or
Tips for Kids is one, then the other one I forgot.
So for those of you who might not be familiar with it, the Nurse Family Partnership in particular is a partnership between a registered nurse and an at-risk or vulnerable first-time mothers, and they partner with the mom starting early in pregnancy and continue the partnership until the 2nd birthday. And the goals are to improve the prenatal care, quality of parenting, and quality of life prospects. And a variety of different studies have shown its effectiveness. There are several different kinds of programs, but from academic achievement, those math and language tests, preschool language, to the days hospitalized that the children has experienced in those 2 years, months between births for the mom, months receiving welfare assistance and food stamps. People who participate have significantly better results. And it is a large expense, and I presented this at the American Association of Indian Physicians conference, and many people and tribal leaders liked and were excited about the results, but didn't have the money to start it up, or it's a very difficult decision. It's, 2 years, 2.5 years of home visiting. But I then shared with them this slide later that there's really strong evidence for cost offset for this sort of program. So $7 on average is returned for every $1 invested. You're in 3 different kinds of programs. Some of them, I think it was a Perry Preschool. I think that is the one that started in Brooklyn by community members. Is that?
Yeah, yes, it's true. I wanted to inform everybody here too that this program, NFP, is one of the models used by the federal government that's approved by the federal government to be implemented at state level. And in Missouri, there are 4. There are 3 others besides NFP, Melissa. And we create a web-based app application and a tool. Diana can get involved in that allows people to assess the fidelity and the quality of the NFP or any other form of implementation in the field. It's by workers, so that's meant for the workers, not for scientists, it's for the people working. So once they do this assessment, the app that we created also allows them to self-train and develop a project and follow up the project of quality improvement until the very end and create a story about it. So it's a whole web application. We're trying to move that now to diabetes application programs in the state of Missouri.
Amazing.
But it was developed for McVie, for all 4 models. And there's also one of our informatics students, Riyadh, remember Riyadh? Yes. He developed Diana, could you explain a little bit quickly what he developed? Is it important for what you say? Because you may find a connection. What you're doing, we may try to go there again. Is Diana still on the call?
Yep, I sure am. You're talking about Riyadh's process mapping?
Yes, I think he did for all 4 models, right?
He did for all of the models, yes. Pretty integrated process mapping, basically on the ground. Each program or each theoretical model and then the program implementation requires certain evaluations to be done at certain age points and time points of their clients that are enrolled in the program. So it's a pretty detailed process mapping of how the program should be operated and when those time and age points should be hit and kind of their educational milestones that they should be hit prior to leaving the program.
So these are informatic innovation about a public health social program in the state of Missouri that we could help that. And now it's being used by the Department of Social Service and the Department of Public Health here in Missouri. We don't have the contract anymore, but we left all these tools created for them. And we're trying to adapt now to diabetes. But it's clearly a program that's important, and we have developed these electronic oriented informatics device to help them implement the program. So I wanted to share that.
Thank you. Maybe you can share the link after.
Sure, we will work with you on that.
There are several tribes that I know about that have implemented some of these programs. One of them, I see there's a comment here, so I'll just read it real quick. This person is in the upper mid-northwest working with her own tribe. And she says it's important to recognize these stats. If we're able to revitalize and recognize roles in our Native communities, we can create more support and stabilization for parents. I believe revitalizing traditional practices has potential to decrease DV and preterm labor. It makes sense that the numbers that indicated that we can decrease traumatic events by revitalizing traditional practices during pregnancy. We can have better overall birth outcomes. And this is a Native birth worker. So thank you. Ms. Dunlap, we're going to actually go right into that topic next. So we talked about when to intervene, and I think that's become clear. And the second component is to tailor the intervention to the population that you're working with. And so within Native communities, there has been a resurgence possibly of decolonizing and privileging Indigenous knowledge. In some communities, these things have just sustained the whole time, but there's more attention to the importance of them in our health. So I wouldn't necessarily say they've been revitalized. Some people have been doing them in perpetuity. Some examples are language immersion schools, cultural schooling, like feeding, bow making, moccasin making, exercising treaty rights, like foraging, fishing, hunting, deer camp. It's time for deer camp right now. And one person said the reclamation of Indigenous heritage, identity, and spirituality would neutralize the pathogenic effects of colonization. So what do we know about how important this is for our health? So Native people that identify strongly and positively with their identity and they take part in traditional cultural activities are more likely to have improved academic performance, positive mental health, reduced substance use. That's in both studies for youth and adults, and improved physical health. So these programs that facilitate cultural knowledge and pride might be able to redress the imbalance that so many Native communities feel and improve health and well-being. And there was a really nice article that came out not too long ago that looked at, you know, when we're talking about culture, language is a critical component of culture. And in our tribe and in many tribes now, there are efforts to revitalize, use immersion schools, et cetera, to ensure that the language doesn't have any, continues to have users of the language. So for mental health, this literature review found that the suicide rate for bands in which 50% of the community is fluent conversationally was 1/6 less than those that are less fluent. In Australia, speakers that have reduced health risk factors such as excessive alcohol consumption, illicit drug use, and violent victimization. In Hawaii, the language immersion school there has a 100% graduation rate compared to the schools that are not language immersion schools for Native Hawaiians. As far as physical health, percent of smokers in tribes where Indigenous languages are spoken is about 14%, but where languages are not spoken very much, the smoking rate is 50%. In Hopi communities, more speakers were classified in a good health wellness category compared to those who didn't speak. And up in Canada, groups who use language more had significantly lower rates of diabetes, even when controlling for socioeconomic factors. So culture and language in particular are really important. So some of the interventions that people have used to prevent and treat heart disease in Native populations, there's very few. And the effective interventions that have been done are difficult to maintain because many of these healthcare facilities are under-resourced. But among the few studies that have used culture as a critical component to prevent or treat heart disease, the most effective ones use case management, family and community support, and cultural adaptation. So one program that used cultural adaptation for diabetes prevention resulted in reduced weight, blood pressure, and blood lipids among Native people. Another study, not too far from here, from Dr. Choi's group at Kansas City, found that a culturally tailored smoking intervention led to higher quit rates among American Indians compared to the non-tailored version. So you can see it's almost double the quit rate when using a culturally tailored adaptive program.
So related to this, are there any factors in the culture that actually promote diabetes? I'm thinking like back home, we eat a lot of pork meat and, you know, so the lifestyle is not, the traditional lifestyle is not really healthy. So is that, are there any factors in the youth culture that basically might need to be adjusted or something?
So that's part of the revitalization efforts is food. So back home in Oklahoma, we eat a lot of fried pork and fried bread.
Right.
That's not traditional food.
No, it's not. Okay.
No, that's post-colonization food. And that's a very interesting and highly debated topic because people talk about the role of fried bread. You can kind of look that up. That's again a whole other topic, that Native people were given commodity foods by the federal government after they were forced to not farm, hunt, and fish the way that they've done for thousands and thousands of years. And they were able to make amazing things out of very limited resources. So there's some strength and resilience there, but we also know fried foods are not good for our heart and many other things. But of course, you know, you're seeing a lot about smoking, and you're seeing a lot about tobacco use, and Native populations Do you use tobacco more than others? But we have a current and historical use of tobacco that's very specific. And so when you look at, there's a Center American Indian Cancer Foundation in Minneapolis, and then there's a couple of other efforts. Keep It Sacred campaign, promoting traditional use of tobacco, which many times is a spiritual use. People don't smoke so much. So that's part of the revitalization efforts.
Yeah, for instance, on this answer, one Northwestern tribes, state of Washington, I visit many projects there. Their problem is because they eat the traditional American diet over the past 40 years, which is pretty bad. And the poorer you are in America, the worse you're going to eat. You're going to have the worst offering of food to your community because healthy food is pretty expensive to eat. Vegetables and fruits and stuff, it's pretty expensive. So
why can't you eat the traditional way? Because you can.
Well, it's traditional, a lot of that is lost. They had to recreate the tradition, like she explained. But the point is, I'm just guessing right now, I'm not saying, but I believe what I saw in the Northwest is the truth of many American Indians. They're just eating that diet, traditional American diet, because they have been incorporating what everybody eats, but they're the poor. If you look at socioeconomic instead of race ethnicity, every poor person in America eats bad for the past 30 years. It's a combination of environmental, social, marketing, psychology, a lot of issues. And it's very cheap to eat badly in America. One gram of sugar is very cheap in America compared to anywhere in the world, especially starch. So that's why. But I think the contribution of diet is as bad as any other American. It's just the other stressors that she said. I think they're very important to make this differential between the American Indian and the other.
So this is a really good segue. I wanted to give a couple of examples of positive interventions that have demonstrated, or culturally adapted interventions that have related to kind of positive heart disease interventions. And we had someone mention the Pima community earlier, and this is again another example of a community that, for me, in my textbooks when I was going through graduate school, was always there and always presented in a pretty degrading way to me. And part of my life, I grew up in this region, but people always put the Pima Indians on this kind of a pillar of negative diabetes health. And I think this is one of my favorite heart disease studies because essentially this is a randomized controlled trial in the Gila River community just south of Phoenix, Arizona. And there was two arms, and this is in the late 90s. This is a fairly old study. And one arm, it was a very formalized lifestyle intervention. You had a journal of diet and exercise recommendations, and you met weekly to ensure that you were following those recommendations. That was the formal arm. And then the other arm of the study was the Pima Pride, and it was an informal study. Informal recommendations. There was a once a month meeting, and the people that came to that meeting, the facilitators were just that, facilitators. So they didn't act in a kind of a teaching role like the other one did. It was more facilitators of a discussion, and they brought in cultural leaders, cultural experts to help lead those discussions, and even did things like basket making, culture lectures, history lectures, etc. Again, once a week, standard, to a once a month kind of culturally focused informal discussion. They even had newsletters, and the actual members could contribute stories about their grandparents, poetry, Pima poetry, things like that. And then the results were pretty impressive. So they looked at 6 months later and a whole year later, and they found that, especially at the year mark, waist circumference, blood glucose, and blood pressure were significantly better in the group that did the Pima Pride group. So the recommendations were that a cultural intervention and an informal intervention with this community is more effective. The other thing I just want to mention about this community, you mentioned food, and the desert food, not food desert, very different, but the food of the desert has properties that have been linked to lowering A1C and blood sugar. But these are foods that essentially have been banned from the community and have only since been revitalized. And so the tepary beans, for example, are related to managing blood sugar. And so, again, when we think about the effects of colonization and the revitalization of language, culture, food, it's kind of a broad
It brings the
ecological.
traditional diet back,
Right.
you know, so.
In another study, same amount of time, they intervened for 12 weeks, a randomized control study. This one was in Hawaii. It's called the hula study, and some people might not be kind of as familiar. Sometimes people think that hula we're kind of thinking about the culturally appropriated version of hula, but this intervention, they brought in cultural leaders, and they did two 60-minute interventions a week, learning about hula, Hawaiian culture, and the cultural protocol with the hula. And they found that they were looking specifically at hypertension, and the intervention resulted in a reduction in blood pressure compared to the control group, significant reduction from the baseline to the 3 months post-intervention. They also looked at quality of life and body pain, and those are significantly improved as well. So the big take-home messages are that metabolic disease starts in utero, stress increases the risk of heart disease, and intervention should start in utero, continue into early childhood, and culture is the heart of Native people, and it has to be the heart of these interventions. Socio-ecological issues must be addressed, and the community needs to be the leader in any of these interventions. So with that, I will end there, a few minutes late. Thank you all.
Well, we're kind of at the end of the thing. Since we had many questions throughout, we have very little time, so actually